This is going to be injury and acute coronary syndromes. Areas to be covered: pathophysiology of acute coronary syndromes. We're going to learn how to recognize and localize the EKG patterns for an acute myocardial infarction. We also are going to look at the indications for doing additional leads, and that's going to be the right leads or right-sided MI and posterior leads. AMI practice, acute myocardial infarction. We're going to look at some 12 leads here. There's 6 of them at the end. If you're wanting to print these off and do them along with the video, their full 12 leads are on your learning management system in the folder called Practice. Pathophysiology of acute coronary syndromes. We're going to talk about in this section ischemia, injury, and infarction, and any type of pathological changes. The first zone we're going to talk about here is the zone of ischemia, and that is this section here. Now remember, this is a transmural event or full thickness, and one of the first glimpses that we get at ischemia is an inverted T wave. So if we see inverted T waves in the actual areas that we're looking at, and that would depend on the camera shot or the lead that we're looking at, then we would consider that that area is ischemic. Now some of the leads actually may have an inverted T wave, like let's say V1 may have an inverted T wave, and that may be a normal finding. After the area of transition, or after the zone of transition, if we see an inverted T wave, we assume or kind of take a look at that might be ischemic. Injury. The next zone that we're going to talk about is the zone of injury, and I'm going to change pen colors here really quick so we can see, which still talking about a transmural event, and we're talking about this red zone here. It's a zone of injury, and in this section we have ST segment elevation. So if we have a zone of injury, and this is highly ischemic tissue, this is almost ready to infarct, what it patterns on the EKG is it gives us ST segment elevation. And again, this is, if we were looking at V3 and we saw ST segment elevation there, whatever zone is associated to V3, that's where we would say that the injury pattern is. Last but not least, infarction. Infarction gives us 2 patterns. And we're talking about this area here that's in the center, the area of tissue that is necrosed or dying, or matter of fact, if it's infarcted, it's already dead. On the front camera shot, we're going to see still ST segment elevation that would indicate that we actually have an injury pattern. Now, deep Q waves can be caused as well, but this is old. And on the opposite side, or the reciprocal lead, we're going to see ST segment depression. And that's only if we have an infarction. So front camera shot will still be elevation. Back camera shot, looking at the opposite lead, is going to be ST segment depression. And this elevation with depression is called a reciprocal change. And it is indicative of an acute myocardial infarction, and I'm talking about the necrosis of the tissue. Recognizing and localizing the EKG pattern for an acute myocardial infarction. We're going to talk about in this section typical distribution of the coronary arteries, the 12-lead map, acute myocardial infarction patterns, reciprocal changes, and confirming an acute myocardial infarction. Typical distribution of the coronary arteries is where we're going to start here, and in the right side we have essentially a right coronary artery, and then it extends around the back and essentially goes in the posterior area. So these are both RCA, or right coronary artery, and then we have this here, which is the left LCA, or left coronary artery. Now, the point being is the way that they're distributed, and we'll see a picture here in just a second. This little section here is considered the left main. And if we get a clot in that, then that means that everything that's fed distal to that could possibly infarct, and that could be up to 90% of the left side of the heart. This section here would be the LAD. This section here would be the circumflex. And we're fixing to see a graphic where we're going to talk about that here in just a second. So, coronary artery distribution. And off of these two holes that are located here and here. Now remember, this fills the coronary arteries during diastole, and that's with the residing pressure that is in the aorta. The flap comes open during ejection and protects the coronary arteries from high pressure. Blood's ejected out. But as soon as this snaps shut, or heads back this way, the pressure that's in this aorta is what perfuses those coronary arteries. That's the first important thing to remember. After that, this section here, if we had an occlusion in it, this would kill off 90% of the left side of the heart. Every place that you see these vessels feeding, and you can see all the way through the back that these vessels here are on the posterior side, distal branches of the circumflex. So, this section is considered the left main. This section here is considered the LAD. And this section that shoots off on the side is considered the circumflex. LAD. This, if there's one running down the side, on the lateral side, it's called the left marginal artery. Left coronary artery or left main. That's what we just got through talking about. Clear this off and then we'll talk about the right side. So on the right coronary artery, it kind of runs diagonal. The posterior descending branch kind of button hooks around the side and feeds the back side of the heart. Now this is translucent, so we can actually see the back side of the heart as well. So this section here, and this is from one of the previous slide sets, that's on the posterior section of the heart is the inferior wall. It is fed by both the right and the left coronary arteries. So if someone has an isolated right ventricular infarction, you can't tell if it's the distal branches off of the left, or you can't tell if it's in the right coronary artery. You're going to have to differentially diagnose. So you don't know with an inferior wall presentation, make this simpler, if your occlusion is in the left coronary artery or the right coronary artery. I'm speaking more of the distal branches back here. 12 lead map. Now, these are the leads as shown on a 12 lead, and what they show us are locations in the heart. Now, 2, 3, and AVF, let's talk about that one first. If we were looking at the heart from above, the inferior wall feeds the conduction system, or essentially the core of the heart. So 2, 3, and AVF see it the best, and the reason that they see it the best is because if we're looking at the heart, lead 2, lead 3, and augmented voltage front look at it the best because it's looking at it all the way through these planes, and 2 of these are bipolar leads, and that would be lead 3 and lead 2. AVF is an augmented lead. So if we see 2, 3, and AVF, that would be the inferior wall, and that's that section on the back that we talked about that's fed by both the left and the right coronary artery. Let's go to V1, V2 here really quick. Explain those. V1 and V2 are the septal area, and I'm going to draw a heart here. V1, V2, and that's because they look at the septal area. V3, V4 look at the left anterior area, and that's why they're considered anterior. V5, V6, lead 1, and AVL all look at the lateral side. So lead 1, AVL, V5, and V6 all look at the lateral side. AVR is way up here at negative 150 degrees, and it is non-diagnostic. It kind of sees everything, run away from it. And I'll explain more of that here in just a second. This is a 12-lead map. What this tells us is where the location of the myocardial infarction is. One more quick redo on this. 2, 3, and AVF are the inferior wall. V1, V2 are the septal wall. V3, V4 is the anterior wall. V5, V6 is the lateral wall. Also in that lateral camera shot, we have AVL and lead 1. This comes up with an acronym to remember this. It's called IC all leads. I stands for inferior, which represents 2, 3, and AVF. S stands for septal, which are represented by leads 1 and leads 2. A stands for anterior, which is leads V3 and V4. L stands for lateral, which you have 4 camera shots there. 1 AVL, V5, and V6. AMI patterns. In this section, we're going to talk about reciprocal changes, inferior, septal, anterior, and lateral wall presentations. And it's pretty easy. If we see elevation in 2, 3, or AVF, that would be the inferior wall involvement. V1, V2, more specifically ST segment elevation or depression. V3, V4, V5, V6. We're also going to look at the indications for doing the VR leads or the right-sided leads, and we're going to take a look at what's different between a right ventricular infarction and a left ventricular infarction. Reciprocal changes. If ST segment elevation is found on certain leads, then on the opposite leads, the patient will have ST segment depression. If you have ST segment elevation with changes in the reciprocal lead, it confirms an acute myocardial infarction. So it works like a teeter-totter just before we even look at this. So if we see elevation in one set of leads, then if we have a reciprocal change, which means that at least one piece of tissue in there is infarcted, we will have ST segment depression. And vice versa. If we have elevation over here, we'll have depression in the opposite leads. If we only see elevation, then right now that patient is ischemic and almost 100% correctable if we get them to a cath lab. Time is muscle, even if they do have a reciprocal change, elevation on one side and depression on the other. We still are going to give them the full court press. Time is muscle. So as we see things like that, we need to get them to facilities as quickly as possible that can use things like angioplasty and PTCA, or PCTA, my apologies, percutaneous transluminal angioplasty. So this is what I like to call a reciprocal change teeter-totter. And what this does, and if we'll make note to these areas here, if we see ST segment elevation in one AVL or V leads, and I'm talking about V1 through V6, if we see elevation here, 2, 3, and AVF is going to be where we're looking for our depression to confirm. Now what this shows us is This camera shot says it's injured. And this camera shot says, yes, I can see the injury. And it looks like a big old hole. Vice versa works as well. If you have ST segment elevation in the inferior wall or tooth or in AVF, that you will have ST segment depression in one AVL or any of your V leads. Identification criteria. So whenever we identify certain specific areas, there's two things that we have to take in consideration. First of all, I must have V1 and V2 to call it septal. And this refers to I must have two contiguous leads to call it that section. Vice versa, all this works all the way across the board. V3, V4 for anterior, V5, V6 for lateral, 1 AVL for lateral, any combination of these, V5 lead 1, lateral. Okay, so I have to have two contiguous leads or two parts of that to say that I have that section. The first words out of our mouth have to be either anterior or inferior if those zones are involved. After that, we can state the secondary injury zones. An example, inferior lateral. This would be 2, 3, AVF, and let's say V5 and V6. Inferior septal, 2, 3, and AVF, V1 and V2. Anterior lateral, V3 through V6. 1 or AVL would also work in this. Anterior septal, V1 through V4. We're going to do some of these here in just a second. So the first words out of your mouth, if they're involved, has to be either anterior or inferior. If you ever stated it in reverse, you'll probably not be looked at like you're educated on reading 12 leads. So an example, if you said anterior septal, that would be okay. However, if you said septal anterior, that would not be okay. Any more than two zones, you apply the word extensive. Now, some people use slang on this and consider them global MIs. So if they have more than two zones, we consider that extensive myocardial ischemia, extensive myocardial infarction, and that's how we assess that and state those injury patterns. So this is the zones. 2, 3, and AVF are the inferior wall, and this is easily identified ST segment elevation in these zones. So if your patient has ST segment elevation in 2, 3, and AVF, they have an inferior wall MI brewing. And the next question is does this person have a myocardial infarction? And the answer is yes. 1 AVL or any of our V leads, this person has a reciprocal change in one of the reciprocal leads. So this person is having an inferior wall MI. Septal wall is represented by V1, V2. These are real 12 leads, so sometimes it's hard to find someone without an anterior section. And the reason being is because the left main and then the LAD and the circumflex are essentially your arteries on the left side. So if I have an occlusion in my LAD, I would affect the zones V1, V2, V3, and V4. All of that, this entire V1 through V4 is fed by the LAD. So again, V1 and V2 are the septal area. V3, V4 are considered the anterior area. This person has elevation in both of those areas. This person also has elevation in the septal area. Again, it's hard to find an isolated anterior or an isolated septal. They do occur sometimes. This person also has a reciprocal change. V3, V4 are anterior. Here's where we had more leads. Lead 1, AVL, V5, and V6 all look at the lateral side. Lead 1, augmented voltage left at negative 30 degrees, 0 degree, and then 5 and 6 on the chest cavity all look at the lateral side of the heart. We still have to have two contiguous leads, so any two of these in any combination would say that the lateral wall is affected. Right ventricular infarctions. The criteria that we're going to learn on the next slide, and I want you all to see it, so I put this up here, is there has to have, first of all, let's just nice and simply state this. If they have any inferior wall presentation, it probably would not hurt you to look right. And I'm going to explain why in about 2 slides. The inferior wall presentation, if there is more ST segment elevation in lead 3 than you have in lead 2, please look right. Please do a right-sided 12 lead on these individuals. This person here does have a V4R, and they are having a confirmed right ventricular infarction. So what is our indications for doing additional leads or the VR leads? There needs to be more ST segment elevation in lead 3 than there is in lead 2. And then again, just to be safe, any inferior wall presentation or in 2, 3, or AVF, you should examine V4R before administering vasodilative agents like nitroglycerin. What is different between a right ventricular infarction and a left ventricular infarction? The differences are, let's say that our patient is preload dependent. And they're preload dependent because the right heart is in the middle of an infarct and it's having a hard time of getting preload or the amount of blood that it needs to into the pulmonary trunk. We have all the vessels here. Vena cava, capillary, aorta, all the way back to the arteries on the arterial side. What nitroglycerin does is nitroglycerin primarily increases the size of our venous container and reduces preload. And what that's going to do to a person that has a right ventricular infarction that's already having problems getting blood into the pulmonary trunk is it's going to reduce the preload even more. This is going to have direct effects and probably reduce our blood pressure greatly or make the patient hypotensive. The treatment is, if we find it, is to give them multiple fluid boluses if they can take it. Now, we have to have some other clinical considerations in on this. Do they have any pulmonary edema already present? Are they already spilling into the previous container? If not, if you think they can handle the fluid challenge, give them a fluid challenge. 250 at a time. A liter or 2 is not too much over what you should be considering for an isolated right ventricular infarction. It uses the law by increasing the amount of preload, Frank-Starling's law. And what Frank-Starling's law says that if we stretch something to a certain point, it has a greater output. This is going to cover 6 12 leads, and the only thing I want you to do in this section is to determine where the injury actually is. So as we go through these, I'm going to point out the injury. Now, what I thought I would do so that we can easily spot them is I'm going to circle the leads with the elevation, and I'm going to put a square around the leads with the depression. So as we start looking through all these 12 leads, we're going to pick one out. That one looks pretty good to me. So elevation there. I got some depression here. I got a little bit of depression started there. Depression. Elevation. If I could draw straight. A little bit of elevation. 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 I would say that that's elevated as well. So all of these circles have elevation to them. And we have depression. Now the question is do we have a reciprocal change? And the answer is yes, we do. So what would we call this? We have an extensive myocardial infarction. The infarction is confirmed by the reciprocal change in 2-3 and AVF. This is number 2. Looking for elevation. I got depression. Maybe a little more depression here. Elevation, elevation, elevation. Probably a little bit of elevation. Just about a millimeter. Do I have a reciprocal change? The answer is yes. I do have a reciprocal change. V leads, 2-3 and AVF would be on my other side of this. So what do I have? An anterior septal MI. This is number 3 on our practice, and we're still looking for injury zones here. Depression, depression, maybe a little depression there. Definitely depression. Elevation, elevation. And depression. Do I have a reciprocal change? I have elevation of 2-3 and AVF and depression. My apologies. I have elevation in 1 AVL or any of our V leads and depression in 2-3 and AVF. However, I still have a reciprocal change. There's also some elevation over here in 4, 5, and 6 that I probably need to watch. This could be a partial wall thickness that's developing currently. Practice number 4. Elevation, elevation, depression, elevation. We should watch this section. Looks like they're fixing to elevate. They're not quite a millimeter yet. However, can I already confirm an MI? And the answer is yes. So I have ST segment elevation in 2-3 and AVF, and I have ST segment depression in 1 AVL in my V leads. Currently I have it in AVL. This person is having a reciprocal change, and they are having an inferior wall MI. Number 5. Depression, elevation, elevation, depression, elevation. If we use this one, then we might be elevated on this side too. So if you don't call it right now, I would definitely watch this section. It depends on which one you look at. You look at this QRS, it's not elevated. You look at this QRS, and it is. Same way with this. The ST segment in this wave looks smaller than the ST segment in this wave. However, I can still report an MI. I have elevation in 2-3 and AVF, and depression in 1 AVL in my V leads. Okay, last one. I have depression, elevation, elevation, depression, elevation. Both sides of my teeter-totter are elevated. However, I can confirm an MI. This person could have triple vessel disease or an occlusion in all 3 of the vessels, the right coronary artery, the LAD, and the circumflex. Or they could just be having the widowmaker, which is in the left main. Either one with this pattern. This is a ton of ischemia. So if you see this pattern and you're out in the field as a paramedic, if you can take another set of hands, you might be doing CPR before you get to the emergency room. This person is definitely on a time clock. Alright, so in conclusion, do we understand what ST segment elevation is? ST segment elevation identifies a transmural event, and it identifies the location of the actual injury. ST segment depression identifies a partial thickness event, or is a reciprocal change of our primary injury zone. When do we do a right-sided 12 lead? If I have more ST segment elevation in lead 3 than in lead 2, I probably need to look on the right side. What are different between a right and a left ventricular infarction? The right ventricular infarction could be preload dependent. At the point that we are using vasoactive drugs and reduce the preload, very simply we could make them extremely hypotensive. IC all leads is a good acronym to remember all of the leads and their associated zones. I for inferior, 2-3 and AVF. S for septal, V1 and V2. A all for anterior, V3 and V4. L for lateral or leads for lateral, V5, V6, 1 in AVL. What is a reciprocal change? A reciprocal change is the opposite camera shot confirming what your primary camera is seeing. So if you see ST segment elevation in your V leads, your reciprocal leads are going to be 2-3 and AVF. References for this lecture came from Volume 2, Medical Emergencies, Maternal Health and Pediatrics of Delmar Learning, and green, 12-lead EKG Confidence, 2nd edition, and the 12-lead map was taken from the following website. If you have any questions concerning this slide set, please feel free to give me a call. My name is Roy Smith, smithr@SamaritanEMSOK.com, or 405-492-8243. Thank you.